Welcome back to the Clinical Education channel. I'm Salah Abbas, and today we are going to talk about colon cancer. So we'll talk about the broad lines of colon cancer. I won't go into specific details of everything. It's just a matter of how you manage the basics of that if you encounter a patient with colon cancer. We need to know some details about the colon cancer. In general, the disease is usually sporadic. It's more common in Caucasian people. Dairy products, eating high fat, have been attributed to that because of the quality of the diet in the Western countries. So the majority are sporadic, and there is a small subset which is inherited. And hopefully we get some time later on to talk about the inherited colon cancer, such as adenomatous polyposis coli and non-polyposis hereditary colon cancer, which is also called the Lynch syndrome. In general, colon cancer is one of the most common causes of cancer death. It ranks number 3 in both men and women. In men, it follows bronchogenic carcinoma in prostate, and in men, it follows breast and bronchogenic carcinoma. Majority of people who get colon cancer are above the age of 50, which constitutes the overwhelming majority. So only a small proportion, which is 10%, happen in people below the age of 50. If you have got a relative with colon cancer below the age of 50, then your risk will be double the baseline risk for the general population. However, if you have one above the age of one relative above the age of 50, then that might increase the risk, but it's hard to quantify. So it's very important to pick those patients who have colon cancer below the age of 50 and talk to their families and ensure they get properly screened. And we'll talk about screening later on. At the level of the pathology of cancer of the colon, we have got what we call the adenoma carcinoma sequence, and I've chosen this diagram for you to illustrate how does the cancer grow from normal epithelium to invasive cancer. Whatever the stimulating factor, whether it's environmental or genetic, the first stage, which is a prerequisite for development of colon cancer, is mutation of the APC gene. It's the adenomatous polyposis coli, the same one that we refer to in patients with familial colon cancer. That's kind of related to the Wnt signaling pathway. And then if you have got only that mutation, there will be a small growth in the epithelium, which is an early adenoma. Usually there is no or low dysplasia. The second step will be the KRAS mutation. The KRAS mutation will promote the adenoma from being totally benign to an intermediate, which has got an intermediate grade dysplasia usually in it. Then another step happens, another mutation comes along, which is the SMAD4. It's also deleted in colon cancer, number 4, but now it's more commonly known as SMAD4. That will lead to formation of what we call a late adenoma, where you have got a large adenoma, usually with high-grade dysplasia. After the high-grade dysplasia, you get mutation of the p53, possibly other mutations. And once you got the mutation of the p53, then it would be an invasive cancer, and then it will progress from that, according to the stage of the disease in the bowel. So The baseline mutation is adenomatous polyposis coli, then KRAS mutation, then SMAD4, then the P53 to have a developed cancer. It's thought that the process in sporadic cancer that take the normal epithelium from the time of the APC mutation to formation of invasive cancer is estimated to be somewhere between 7 and 10 years, and hence there's a long lag between the development of adenomas and carcinomas. This is also manifested in the community. So people with polyps without advanced cancer, they have the mean age of around 50, while people who have colon cancer, they have the mean age of around 60 or so, which means that there is definite lag between the formation of the polyps and the invasive cancer. And the role of surveillance in that case is what we get from the latency period between the first mutation to the invasive cancer. So again, so it's the same thing, the adenoma carcinoma sequence, but here I want to talk to you about colon polyps and the fact that they represent as a precursor for colon cancer. Not all polyps will develop into cancer, but it is estimated that more than 1/3 of them will actually progress to become invasive cancer. Microscopically, they can be divided into a few varieties. The most common one is the tubular adenoma, followed by the villus adenoma, and also we have a mixed one, which is tubular villus adenoma, because serrated polyps, which are most commonly seen in the right colon and the cecum, and we've got hyperplastic polyp, and they are not neoplastic, so they're harmless, and they're most commonly seen in the rectum and the recto-sigmoid junction. If we find about them, we generally, if we are confident, we ignore them. If there is any doubt or uncertainty, we sample that or remove one of them if there are multiple for histologic confirmation. Now, adenomas or polyps will grow in size gradually, and the risk of having cancer in the polyp is related to mainly two factors. One of them is the size of the polyp, which means that polyps that are above more than 2 centimeters, 50% of them will have malignancy already established in them, compared to less than 5% in adenomas that are less than 1 centimeter. As I said, also the villus pathology, the tubular villus adenomas tend to be more aggressive, and they are likely to progress to cancer. The benefit of colonoscopy comes in the removal of the polyps, and in theory, and proven that also practically, that removal of the polyps and regular surveillance of patients who has developed polyps in the past is useful, because we can find the polyps and remove them, and that will prevent the development of cancer. Now, clinical presentation, how do they come to our attention? There are a variety of ways. One of them, they could have abdominal pain. Usually the abdominal pain that happens with large bowel is caused by near obstruction or obstructive lesions. And the pain usually is across the lower part of the abdomen. So it's an inferior abdominal pain in the infraumbilical region. Cancers will ulcerate, so they bleed. And if they bleed, they will manifest in a variety of ways. Number one, rectal bleeding. Now, the bleeding that happens from colon cancer is different from melena and different from fresh rectal bleeding associated with hemorrhoids. Usually, the color of the blood is kind of maroon, altered blood, because it would have had enough time for some of the hemoglobin in the blood to be deoxygenated to become dark color. So it's darker color, but not black, dark red. They could manifest in the form of anemia. The patient could be having investigation for other reasons, or they are feeling fatigued, or they had a routine blood for another reason, and they found they've got anemia. And once we find anemia in general, you'll find that we will need to find the reason for that. So they get investigated, and in these situations, we assume they are losing blood in the gastrointestinal tract, and that will not be manifested as change in the color of the stools, but only anemia. Also, it could be iron deficiency for the same reason. And iron deficiency is, in general, is a common thing, but we would take it more seriously in male patients and also non-menstruating females. Females at the child producing age, they could have heavy periods, and a lot of the iron deficiency is related to heavy period bleeding. Iron deficiency could also be dietary, and it is a non-specific test. Sometimes people do have iron deficiency and they have normal hemoglobin level, and that can be hard to ascertain the cause of the iron deficiency, likely to be related to other systemic illnesses like kidney disease or so. Now, in patients with, having said that, with the bleeding, not all of the patients with colon cancer bleed. We have to keep in mind that 1/3 of the patients, they do have normal hemoglobin, and if you do an FOBT, fecal occult blood test, will be negative. So it could progress and develop into a significant cancer at a significant stage, could even be metastatic in the presence of normal hemoglobin and no detected blood in the bowel motions. And that applies to about 1/3 of the patients. An important presentation of large bowel obstruction is of the colon cancer is the large bowel obstruction, and the most common place where the large bowel get obstructed as a result of cancer is the rectosigmoid junction or the sigmoid colon, and it is one of probably the most common place where cancer of the colon arises. So these patients will present a large bowel obstruction as constipation, distended abdomen, and abdominal pain. We do scan for them and we find they've got large bowel obstruction, and generally large bowel obstruction in most of the instances is a surgical condition that will likely need surgical intervention rather than non-operative management as compared to the small bowel obstruction. Patients could come with systemic symptoms, and one of them is fatigue as a result of anemia. They could be losing weight or malnourished. Occasionally, colon cancer, and that's not a common presentation, but it could happen. It could manifest in the form of a colovesical fistula that typically occur in cancer of the sigmoid colon, because the sigmoid is redundant, and the curve, the top of the curve part of the sigmoid could overlie the urinary bladder, and as a result of tumor growth, it can invade into the bladder, leading to the fistula. It is an uncommon to present in that situation. Very occasionally, we could find cancer as an incidental finding, and that can happen as a result of imaging for other reason. The colon cancer is not generally diagnosed by CT scan because it's not designed to do that. However, if there's a large mass, the CT scan could pick that. Very occasionally, I have seen patients who had laparotomy for other reasons, like a trauma laparotomy, and during that they found to have cancer of the colon. So there are a variety of ways about finding the colon cancer. Now, once it came to our attention, I should mention to you that it could be sometimes difficult to diagnose colon cancer. Patients could present with liver metastases, and that can be either as a result of right upper quadrant pain or another reason, and they get a scan and we find liver metastases. And whenever we find liver metastases, you'll find that the surgeon would recommend upper and lower GI endoscopy because the most common source for liver metastases is the gastrointestinal tract. Increasing fatigue as part of the problem, which is related to the systemic symptoms of colon cancer. A very important type of presentation is a recent change in bowel habits, and that's usually in the form of constipation or going infrequently or feeling inadequate emptying in some patients. Now, changing the bowel habit in general is a relatively common complaint, and often it is related to non-organic disease, functional disease, like irritable bowel syndrome. But if the patient complains of definitely recent change in their bowel habit, should take that seriously, and we advise them to have a colonoscopy. Now, colon cancer can arise in patients who has got ulcerative colitis or Crohn's disease, the inflammatory bowel disease, and these patients will be under surveillance for their primary disease and also the fact that they could get cancer. So they would have periodic sampling and scoping of their colon, and during that surveillance, sometimes colorectal neoplasia in the form of polyps or cancer could be found. How do we diagnose colon cancer? If any of the previous symptoms that I have mentioned raised, or the possibility of colon cancer raised, then the gold standard to do a colonoscopy, and if we find cancer, we do take biopsies from that. And it's obvious if we find polyps that are removable, they will be removed at the same time. But often, if there is established cancer, the role of colonoscopy will be to establish the diagnosis, and then it will be dealt with surgically, as we'll see in the treatment. Colonoscopy will show us where the tumor is. We will be able to visualize the tumor in its macroscopic level, and also the histologic level that will come from the biopsies. It can also show us the extent of the constriction. If the patient is if it is obstructive or nearly obstructive, they might need more urgent operation, particularly in the left colon. Now, in 3% of the of patients who have colon cancer, we could have another lesion, a synchronous type of colon cancer. We could find polyps in the rest of the colon, and obviously these will be removed. So once we have established that the patient has got cancer of the colon, regardless of its location, excluding the rectum, of course, here I'm talking mainly only about colon cancers. You will find that we will get a CT scan of the chest, abdomen, and pelvis, just to ensure there are no metastases in the liver or the lungs. And also, it might help us to quantify the original disease. And if there are bulky lymph nodes that are suspicious, CT scan will be able to pick that. PET scan is part of the routine, and that's mainly to exclude metastases anywhere in the body. They get level CEA level, which is the tumor marker that comes with the colon, carcinoma, embryonic antigen level, and that is useful. It's not diagnostic by itself, but it's useful in follow-up and surveillance after the surgical treatment of colon cancer. Now, what do we do if we find colon cancer? Now, the answer is generally, with the exclusion of patients who are terminal with distant metastatic disease, or they are unwell for other medical problem when they are not suitable for surgery, who will get palliated, this will be excluded. And the main reason for the palliation is either the patient is unhealthy and unable to tolerate an operation, or the disease is advanced and there is unresectable metastatic disease. And in that case, it could be just palliative treatment in the form of palliative chemotherapy. Otherwise, surgery will be indicated for suitable patients, and the surgery is based on the blood supply of the colon. So I will go over the blood supply of the colon. And as you see in the picture, with the superior mesenteric artery gives the middle colic, which gives two branches, one to the left, one to the right, and then we give the ileocolic, which provides the blood supply for the terminal ileum and the right colon up to the flexure, the hepatic flexure. Now, sometimes there is another branch that comes off, either takes off early in the pace from the right colon or main stem SMA, or from the ileocolic and goes directly to the hepatic flexure. The middle colic supplies the rest of the colon up to the splenic flexure. Now, that's where the role of the superior mesenteric artery ends. So the gastrointestinal tract is supplied by the SMA, the superior mesenteric artery, from the ligament of Treats, where the duodenum joins the jejunum, to the splenic flexure. After below the splenic flexure, it will all be supplied by the inferior mesenteric artery. Inferior mesenteric artery usually gives a left branch that goes up toward the top of the left colon, and it gives usually several sigmoid branches, and then it will end up in here as the rectal artery, which supplies the upper 2/3 of the rectum. Now, there is usually good anastomosis between the circulation of the inferior mesenteric and the superior mesenteric in the form of this picture frame vessel that goes around along the colon, which is called the marginal artery of Drennan. Marginal artery of Drennan provides the overlap in the circulation, which will be useful in cases if one of these vessels is diseased. You will find there's possibly the other vessel will take over. And we have seen instances where the SMA is heavily diseased, the inferior mesenteric artery became really large, and it provides blood supply to the entire colon through the anastomosis in the existence of the artery of Drennan, the marginal artery of Drennan. So we base the surgery on the blood supply. So keep the blood supply in mind, and then we go to the terms. What do we do for what sort of surgery that you will hear about? So we'll have, start from the right side, we have right hemicolectomy and extended right hemicolectomy. So what we mean when we say right hemicolectomy, it means that we remove the terminal part of the ileum, which is around 15 centimeters, 20 centimeters of the terminal ileum, including the valve, the cecum, the ascending colon, up to the hepatic flexure. This part of the colon, as we said, is supplied by the ileocolic. So when we operate on these patients, we will dissect the mesentery up to the and close to the origin of the ileocolic from the SMA in order to be able to sample the lymph nodes, and the lymph nodes will be lying along the blood vessels, and we need to take at least 14 lymph nodes. When we say extended right hemicolectomy, we mean that we have removed part of the transverse colon also, and that can extend from the terminal ileum up to the splenic flexure or nearby. And that usually is indicated. Extended right hemi is usually the treatment that is recommended for cancer of the transverse colon proximal to the splenic flexure. So anywhere between the splenic and the hepatic flexure is a transverse colon, and that cancer is taken along with the right hemicolectomy. There are places in the world where they do transverse colectomy, but it is not a popular procedure, and you will find that hardly anyone does it in Australia. And then you hear the term the left hemicolectomy. The formal left hemicolectomy is dividing the colon just above the splenic flexure. So we take part of the distal transverse colon, We mobilize the splenic flexure, we mobilize the left colon up to the junction between the left colon and the sigmoid, and then that will be removed along with the sigmoid vessels and the left iliac artery. Very often you will see that this operation is performed in the form of what's called an anterior resection as well, particularly if the cancer is situated in the area of the rectosigmoid. So this one will be suitable for cancers. Sorry, this one, I mean the left hemicolectomy, will be suitable for cancer of the proximal descending colon and the splenic fracture, or the part of the most distal part of the transverse colon. So you hear that term as well, and that's what it means. It means that the sigmoid vessels and the inferior rectal artery will remain untouched, and we are removing the territory of the left branch of the inferior colic artery. Sorry, inferior mesenteric artery. You will hear the term of sigmoid colectomy. Now, general sigmoid colectomy is not a common procedure that for cancers in particular. It is a procedure that can be done for benign disease. When I say benign disease, I mean it's mainly complications of diverticulitis, such as recurrent attacks of fistula formation or multiple abscesses. People get troubled sometimes by recurrent attacks of recurrent colitis, where we recommend elective surgery for the sigmoid, to remove the sigmoid colon and join the descending to the upper rectum. Another term that you should be familiar with is the Hartmann operation. A Hartmann operation is an emergency operation. Usually, it could sometimes be performed in elective situations for a variety of reasons, but the most common indication usually is perforation or obstruction. Perforation usually caused by diverticulitis or cancer to less extent, and obstruction is more likely to be a cancer, but it's possible some diverticular stricture could lead to obstruction. And in that situation, you'll see the surgeon will take the sigmoid part of the colon. We will staple off the upper end of the rectum and leave it in the abdomen, and we mobilize the colon, the left colon, and the splenic flexure to bring a colostomy. And that colostomy could be either permanent or temporary. Generally, when we do it, we assume that we should be able to reverse it, but at certain situations, or in some patients, depending on their condition, we might sometimes relieve them with their permanent colostomy. Right. So the patient had their surgery, and that after surgery, what will happen? Then we will get the stage of the tumor. So I encourage you to familiarize yourself with the universal TNM staging, and that will dictate the rest of the treatment after the patient has recovered from their surgery. Now, in general, T1 and T2 are unlikely to require chemotherapy unless there are aggressive features, but T3 requires chemotherapy. Any lymph node metastases, patient will require adjuvant chemotherapy, and you'll find that the most common form of chemotherapy that's employed, if the patient tolerates that well, is the FOLFIRINOX, which is a combination of 5-FU plus oxaliplatin plus another agent. If they have got high grade if we have high-grade tumor with lymphovascular invasion, that will be discussed in an MDT, and usually the feeling is that if there are high features, then the patient should have adjuvant chemotherapy, even if it is T2 lesion. Now, we assume that the patient had their cancer removed, they had their chemotherapy, or they didn't need their chemotherapy, then we follow them up. And the follow-up is based on 3 monthly CEA. We do an annual CT scan. If the CEA start to go up, then at that stage we do a CEA we bring it forward. That type of follow-up. follow-up will be for at least 5 years. Then we recommend a colonoscopy for them in 12 months, and the purpose of that to ensure no recurrence of polyps. And then if they are clear, then it will be 3 years and 5 years. That could be shortened if we find polyps. So that's the follow-up for the management of colon cancer. And during their follow-up, some of them will develop metastases, and in particular liver metastases, and they might be suitable for surgery. Thank you much for hanging around with me on this session, and hopefully I will be able to make you more videos in the future. I will see you in the next lesson.